Thank you very much, Mr. Chairman. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah wa salatu wa salam ala Rasulillah. Today, where is the controller? Can I have a controller? Today, our topic is about the updates of the neuromuscular blocking in the American Society of Anesthesiologists and the European Society of Anesthesia and Intensive Care. Here's my disclosure. Today's event, of course, is sponsored by MSD, and I'm working for Dr. Sulaiman Habib Hospital. Safe, balanced anesthesia. Safe anesthesia is the target of any anesthesiologist. And the safe anesthesia you deliver, you need it to be balanced. Balanced anesthesia is to achieve autonomic attenuation by a triad. The triad, which we all know, by maintaining analgesia, hypnosis, and relaxation. And this triad leads to narcosis. So relaxation is an essential part to reach a balanced anesthesia. Here's some questions which we need to ask ourselves. And most of anesthesiologists have some debates and difference in practice. And today we are going to answer these questions. The first question, do we need muscle relaxants for tracheal intubation? Second question, does it worth to do a deep neuromuscular blocking? The third question, when you reverse the neuromuscular blocking agent, would you use neostigmine or use sugammadex? And the fourth question is, do we need neuromuscular monitoring for some delay? Do we need neuromuscular monitoring when we use neuromuscular agents or not? I want to know the answers which you believe first, then we will answer these questions together with evidence. First, do we need muscle relaxants for tracheal intubation? Some of anesthesiologists believe yes, for every patient I have to intubate with endotracheal tube, I need to give muscle relaxants. And some of anesthesiologists, they believe no, not all patients. I'm not speaking out of this question, the patients who are contraindicated for muscle relaxation. I'm speaking about patients who don't have problem in receiving muscle relaxation. Please, from the audience I see here, tell me who believes that neuromuscular blocking is essential for endotracheal tube. Please raise your hand if you believe it. Okay. If you believe that in some patients who is not contraindicated to receive neuromuscular blocking, in some patients you can intubate your patient with endotracheal tube without need of muscle relaxant. Please raise your hand. Okay, I can see here about 50% to 50% who believes, the anesthesiologist who believes that neuromuscular agents is essential, and 50% who believes it's not essential. About 10 years ago, there was a survey done in Europe. This survey is done on 17,150 patients who received neuromuscular blocking agents. From these 17,000, more than 10,000 of these 17,000, they have no neuromuscular monitors. And more than 12,000, they are extubated on clinical criteria. And more than 8,000 didn't receive any reversal agents. And only 2,839 patients out of 17,000 patients, almost 15% of this number, they were extubated based on turn of 4 more than 0.9. According to these variations, there was need to guidelines which guides the anesthesiologist how to use neuromuscular agents safely. If you look here, this is a timeline showing the guidelines starting from 2010 till 2021, and now we have updates in 2023. Speaking about neuromuscular agents, starting with the European Society Helsinki Declaration in 2010. Then in 2010 there was a Czech Society of Physiology and Intensive Care Medicine Guidelines. Then comes the European Board of Anesthesiology Guidelines. 2017 the Australian. 2018 the consensus statement published in anesthesia in US and analgesia. Then the Japanese Society in 2019. Then comes on until 2000. I think the most important is the French one in 2022, and the most recent are the two guidelines which we are going to discuss today. The American Society of Anesthesiologists and the European Society of Anesthesia and Intensive Care, they published for the European one, it was declared on very recently, last November, and on January 2023, it was published in the European Journal of Anesthesia, and a month after, on February 2023, the American Society also, they published practice guidelines for monitoring and antagonist of neuromuscular blocking. And these are the guidelines which you are going to discuss today. What is the evidence based on these guidelines? If you look to this trial was done on 2002. It's done on 60 patients, and they were trying to intubate patients without muscle relaxants. And they were trying to intubate the patients using remifentanil only and propofol. They were using propofol 2 milligrams per kg and remifentanil on 3 doses. And the comparison was between the 3 doses, which is 3 mic per kg, which they call it as R3 group, and 4 mics per kg, which they call it as R4 group, and 5 mic per kg, which they call it as R5 group. And they were checking how is the status of the intubation in this between these two groups. Actually, in the group of 3 mics per kg, they found 12 out of 20 patients, mean about 60%, only who have excellent and good conditions, while the remaining 40%, they have poor conditions of intubations. And for the group which received 4 mics per kg and 5 mics per kg of remifentanil, they 19 out of 20 had a poor condition. But if you look down here to the graphs, this is a graph showing the mean arterial pressure and heart rate. When you are administering the 4 mics and 5 mics per kg remifentanil to the patient, there is a great alteration on their hemodynamics. And about 50% of these patients needed medications to correct the hemodynamics, correct the mean arterial pressure, and correct the heart rate when you give these doses, which is 5 mics and 4 mics per kg remifentanil only without using muscle relaxants. Another trial, which they used 68 patients on a double-blind study, and in this study they tried to replace muscle relaxation, which is rocuronium. They tried to replace with magnesium sulfate. Everyone knows that magnesium sulfate has a feature of autonomic stress. It alters the autonomic stress, and it has a muscle relaxation criteria. So they tried the magnesium sulfate. The first group received 50 milligram per kg, and they call it like a GM group, which is a group received magnesium. And second group received 1 milligram per kg of rocuronium, which they call it as a GR group. And they evaluate the conditions of, here's the table which contains how they evaluated the conditions of anesthesia. And out of the study done on 68 patients, so 34 in each group. Out of 34, 24 of the patients of the rocuronium down there, 24 of them has excellent conditions for intubation, while 10 has good conditions for intubation, and 0 of the rocuronium group has a good conditions of intubation. While in the group who received magnesium, 29 out of 34 had poor conditions for intubations. The trials we mentioned before, they were trying to replace muscle relaxants because they don't want the muscle relaxant side effects like residual neuromuscular blocking and their side effects. But we see in these trials the effect of neuromuscular blocking was superior to the effect of the replacements like we see in the previous trials on remifentanil and magnesium. In this trial, they tried to compare between patients who received muscle relaxants and patients who didn't receive muscle relaxants. And they compared both on post-operative symptoms, nasopharyngeal symptoms. And This comparison the aim is to find out if there is a high risk for oropharyngeal trauma in patients who didn't receive muscle relaxant versus the patient who received muscle relaxant. When we see here the control group, which are the group who didn't receive muscle relaxants, after 2 hours, 57% of them has a post-intubation symptoms, while the recurrent group only 43%, and after 24 hours, 38% of the control group who didn't receive muscle relaxants versus 26% from the group who received muscle relaxants. And if you see the table 4 here on the left, the number of attempts is increasing while you are not using muscle relaxants, and also number of operators is increasing when you are not using muscle relaxant. So, of course, the risk of trauma and risk of oropharyngeal trauma is increasing when you are not using muscle relaxant for intubation. Okay, then we see in this study. This study is, you can say, a mega study, which is done on 103,000 patients, and it's a cohort study. It's done by the Danish Anesthesia Society, and it's done from 2005 to 2007 on big number of patients. And they were comparing between patients who didn't receive neuromuscular blocking agents and they intubated, with the patients who received non-depolarizing muscle relaxants and patients who received a depolarizing muscle relaxant. If we look down here to the risk of difficult intubation, the risk here of difficult intubation on the patient who didn't receive muscle relaxants was 6.7%, while in the non-depolarizing muscle relaxant it's reduced to 5.1%, and for the patient who received depolarized muscle relaxants, it decreased to 1.9%. This is a Cochrane systemic review speaking about avoidance or use of neuromuscular agents and outcomes on the tracheal intubation. If you avoid muscle relaxants to intubate the patients, what will be the outcomes? The primary outcomes here was difficult tracheal intubation. In the group which you didn't use muscle relaxants, the percentage of possibility of difficult tracheal intubation was 56.3% versus only 4.7% for the population who received neuromuscular agents. And this result comes from 4 trials and 508 patients. The other primary outcome is upper airway discomfort or injury. Here, according to 7 trials and it's done on 846 patients, it's 38.2% for the population who didn't receive muscle relaxant versus 27.3%. And for secondary outcomes, they spoke about difficult laryngoscopy conditions, which was 7.2% in the population who didn't receive muscle relaxant versus 3.3% for the population who received muscle relaxant. And in the conclusion of this Cochrane systemic review, they said that the review supports the use of neuromuscular blocking agent may create a better condition for tracheal intubation in clinical practice. According to 39 randomized clinical trials and 1 cohort study and 2 systemic reviews and 1 clinical guideline, we had a recent guideline comes by the European Society of Anesthesiology and Intensive Care, which says we recommend a use of muscle relaxant to facilitate a tracheal intubation, which has a good, high quality evidence and a strong recommendation. And there is another recommendation, which is we recommend the use of muscle relaxants to reduce the pharyngeal and or laryngeal injury following endotracheal intubation, which has a low quality of evidence and a strong recommendation. Regarding the laryngeal muscle airway, there is no mention for the laryngeal muscle airway in the recent guidelines, but I found 2 interesting trials which I would like to share. Regarding there was a trial in using Procil, LMA Procil, and they were comparing the insertion of LMA Procil using a neuromuscular agent or without, and the conclusion of this study says the muscle relaxation appears to facilitate the insertion efficiently and enabling successful insertion. And there is also another paper which compares between insertion and ventilation of laryngeal mask airway, and it was comparing between the positioning of the patient in a sniffing position and insertion of LMA with muscle relaxant. And the third group, they used both methods, sniffing position and laryngeal mask airway. And here, if you check the results, you find the patients who received, who are in sniffing position. I cannot see the numbers from my side here, but you can see it's about 10 seconds compared to, I think, 6 seconds in the patient who has who received muscle relaxant. And if you look, I cannot see the number efficiently from my place, but you see the patient who were in a sniffing position and also when received muscle relaxant during insertion of LMA has less time for insertion of LMAs and has least less peak pressure during ventilation with LMA. This is also a trial of rapid sequence induction. It was a comparison between using Sogomedex, we're using rocuronium with Sogomedex versus using succinylcholine. Actually, succinylcholine was used before for many years as an induction agent in rapid sequence induction. But as we know, I didn't use succinylcholine since maybe 10 years, but what I remember when I was using succinylcholine, the patient was fasciculated on the tables with a lot of contractions, and you know, fasciculation and contraction means increase in the intra-abdominal pressure and higher risk of regurgitation and aspiration. Most of the reviews, they said that the conditions of intubation using the succinylcholine, it's better than the conditions given by rocuronium. But the risk of aspiration using succinylcholine is much higher than the risk of rocuronium. If we see in this study, the comparison between using rocuronium with Sogomedex and succinylcholine, and we see here in the results that the time from the start of the procedure to ventricular intubation was less in the group used rocuronium and Sogomedex, and also the intubation conditions. Here in this study, it says that the conditions was 93% versus 36 excellent conditions in the rocuronium group. And in intubation difficulty score, it was better in the rocuronium group. Also, the time from tracheal intubation to spontaneous ventilation was better in the rocuronium. If we compare here, the average is 2016 seconds. It's 216 seconds versus 400 seconds in the reversal. And the time from tracheal intubation to reach the 90% TOF, which is a reversal time, it's much less in rocuronium because you are going to use Sogomedex. And the time from injection of neuromuscular blocking to reach the time of intubation is much less, 280 seconds versus 719 seconds. And here, this systemic review, which is Cochrane systemic review, it says that the review summarizes, it's done on 50 trials in 4,051 participants, and it recommends that, however, if an alternative agent is required, rocuronium 1 mg per kg can be used to create acceptable condition in intubating patient with rapid sequence induction. Now, the guidelines, which is today's guidelines, comes from the European Society. They say we recommend the use of fast-acting muscle relaxants for rapid sequence induction, such as succinylcholine on a dose of 1 mg per kg, or rocuronium from 0.9 to 1.2 mg per kg, which is moderate quality of evidence and strong recommendation. But they put one condition, that if you are going to use rocuronium as an agent for rapid sequence induction, Sogomedex should be available inside the operating room, not inside the OR theater. And if you are going to induce your patient for rapid sequence induction with rocuronium, Beside you, there should be Subumadex ready for injection in case you need to reverse your patient. That's the recommendation comes from the European Society. I think now we answered our first question, which is, do we need the muscle relaxant for injection tube? Let's go now for the, does it worth to give deep neuromuscular blocks? Deep neuromuscular blocks, you know, there is a lot of burden on the cost because you are going to use more drugs. Is the benefit comes from the deep neuromuscular blocks is beneficial or not? Please, from the audience, I want to know your opinion. Who thinks that deep neuromuscular block is beneficial for, I'm speaking regarding the group of patients who are going to do laparoscopic surgeries. Who thinks that the deep neuromuscular block is beneficial to the patient, and the burden of increasing costs by drugs, it's really worth it to give your patient? Please raise your hand.
For laparoscopic surgeries.
I'm speaking about laparoscopic surgeons. Who think that deep neuromuscular block is okay? We're speaking about maybe 50% of audience, and I think the remaining who believe that deep neuromuscular block is not necessary in the laparoscopic surgeons. Let's answer this and find out what the guidelines says. Inside OR, there is two lines of interest: the line of surgeon and the line of the anesthetist. Usually, parallel lines, they never intersect, they never meet. But inside OR, for the benefit of the patient, these parallel lines should by the end intersect for the benefit of the patient. The surgeon line of interest aims to be fast, have an easy access, do no injury and no harm to his patient, and has no bleeding. That's his interest. That's what the surgeon thinks about. And what the anesthetist thinks about? They think about to have a stable vital signs, to have a fast recovery and go home early, to have no new neuromuscular blocking residuals, and to have no pain to your patients in the backward recovery area. From a surgeon's perspective, there are two basic questions related to neuromuscular blocking. What are the components of an ideal surgical condition, particularly during laparoscopic procedures? And what are the challenges in achieving the ideal conditions? And to answer these questions, we have to know what is the meaning of ideal surgical conditions. Ideal surgical conditions means to have a larger operative space and to have an access to tight spaces, also to have a better visualization, and to have immobilization, which is very important in laparoscopic surgeries, because in case the patient cough or move during laparoscopic surgeries may lead to a disaster. Inside the abdomen, there is a lot of vital organs, viscous, vessels, big vessels. If a patient cough or move on the table and the surgeon has an injury to any of these organs inside the abdomen, the surgery will become like a disastrous scenario. And the last thing is to have a lower insufflation pressure. And lower insufflation pressure actually is related to pain, post-operative pain. If you have a lower insufflation pressure, you will have less post-operative pain. Let's, in fast, define what's the meaning of moderate neuromuscular blocking, because we are going to speak a lot in the coming slides now about moderate and deep neuromuscular blocking. Let's remind you in fast, moderate neuromuscular blocking means that the 3 or 4 monitor gives you from 1 to 4, and the deep neuromuscular blocking means that the 3 or 4 count to 0, you don't have reading on 3 or 4, and the hospital count is from 1 to 2. That's the meaning of deep neuromuscular blocking. And the definition of moderate and deep neuromuscular blocking, it has a different definitions, okay? And I mean, according to the trials and papers which I searched in each trial they have a different definition in depth of neuromuscular blocking. But these two definitions are the average definitions which you are going to, most of the papers which I will discuss now depends on the deep means that the count of hospital count is ranging from 1 to 2, and the moderate means that you have at least 1 twitch from 3. Let's have a question. Are we, as anesthesiologists, able to measure the quality of surgical condition from a video image? When you are inside OR and the surgeon is telling you that the patient is tight. When you have a look on his screen, are you able to measure the quality? And or argue with your surgeon, no, the patient is not tight, I can see the field is okay, you are asking for more drugs for nothing. Can we measure? Please, if you believe that you can have, you can estimate or you can measure if that is a working space is good or not, please raise your hand if you believe that you are able to measure that. Okay, I cannot see anyone raising his hand. And this common interesting paper, which is published in the British Journal of Anesthesia, they were comparing between patients who received moderate neuromuscular blocking and deep neuromuscular blocking. And actually, they asked anesthesiologists from outside the field, not the primary anesthesiologist, and they asked surgeons from outside the field, not the operating surgeon, to evaluate the images. Okay? When we look here to anesthesiologists, the anesthesiologists have more estimation. They have more measurements of if you look to the graphs here, the number of anesthesiologists we are thinking about 45 maybe anesthesiologists said this is a very good condition versus only 30 surgeons. So your eyes to the video image has a different evaluation measures than the surgeons. So please, when your surgeon asks you for a muscle relaxant, don't argue with your surgeon, because the surgeon has a different view to the video image than the anesthesiologist has. These French Society Guidelines, which we spoke about before in 2022, 2020, and it was the most important guideline before we have the recent guidelines. In the recommendation 5.1, they put a strong agreement that muscle relaxants, they recommend that it facilitate intervention procedures in abdominal laparotomy and laparoscopy surgeries, because before this there was a lot of trials to do laparoscopies and laparotomies without muscle relaxants. And here comes this guideline says, no, we recommend that you must use a muscle relaxant in doing laparoscopies and laparotomies. If you look to these studies, is done on bariatric population, bariatric surgeries, and it's comparing deep versus deep neuromuscular blocking versus moderate neuromuscular blocking. And in this comparison, we can see here 5 here is the best condition and 1 is the worst condition. In the population of who received deep neuromuscular blocking, we see here from the graph that the people who received neuromuscular blocking has a better surgical field evaluation, and they have a better surgical condition. Also, another study which is done in laparoscopic hysterectomy, we see also the deep neuromuscular blocking give us a better surgical conditions for the surgeons. Comes another study which is done on the laparoscopic renal and prostatic surgeries, comparing between moderate and deep neuromuscular blocking, and we see here in the for optimal conditions, which is have a score of 5, about 100%, 10% has an optimal conditions in the moderate block, while in the deep block 70% from has good conditions. And for good conditions, 20 versus 20, acceptable conditions, 10% versus 25%, and in extremely poor conditions, we have a 5% of moderate block had an extremely poor condition versus 0% for the deep neuromuscular block. We see here also in the systemic review published in the European Journal of Anesthesia, it says that the deep block was associated with excellent or good surgical rating score frequently than the moderate block. Another review also, a systemic review, which is comparing the deep and moderate neuromuscular blocking, which says that findings suggest the use of deep neuromuscular block may improve the patient and physician surgical experience by improving certain patient outcomes, such as post-operative pain and improved surgical readiness. Another systemic review, and in systemic review, the conclusion says that in conclusion, this systemic review shows that the deep neuromuscular blocking helped to improve perceived surgical space condition and reduce post-operative pain and patient undergoing laparoscopic bariatric surgeries. Another systemic review and meta-analysis also published in the British Journal of Anesthesia, which says that the use of deep neuromuscular blocking during laparoscopic surgery improves the surgical space condition when compared to moderate neuromuscular blocking. So we have now a clear guideline which comes from the European Society of Anesthesia, says that it recommends dealing with neuromuscular blocking if surgical conditions needs to be improved. So in this, which has a moderate quality of evidence and strong recommendation. So it's known and proved and comes in the guidelines that deep neuromuscular blocking, it improves the surgical space. But in other trials, you can see in this trial, which is done on 100 patients, and these patients, they were going to be evaluated by 3 surgeons every 10 minutes, and evaluated by surgical rate scale, and they were evaluating their pain in the post-operative, in the recovery area. And if we see here, the pain score in the post-operative post-anesthesia care unit in the people in the population who received a deep neuromuscular block is much less than the population who didn't receive deep neuromuscular block or received moderate neuromuscular blocking. And also the pain of the ward, like superficial pain and deep wound pain, is much less in the population who received a deep neuromuscular blocking compared to the population who received moderate neuromuscular blocking. But actually the guidelines, they said that there is insufficient still evidence to recommend that deep neuromuscular blocking in general is to reduce post-operative pain. Till now, we don't have a clear proof. There's a lot of studies which describe that there's a link between the post-operative pain and the deep neuromuscular blocking. But until now, we don't have a clear evidence that there is a real relation between post-operative pain and giving a deep neuromuscular block.
What do you mean by post-operative pain? Specific surgical pain?
It's here in
or shoulder pain?
It's a variation of pain. So yeah, if you look to this study, it's they divide like pain in recovery and here and they categorize from deep wound pain and superficial pain score. You are speaking about pain as all, okay? But theoretically, we are speaking about shoulder pain because of stretch on the diaphragm. This is theoretical. But on this trial, it's comparing the superficial and the deep pain, and they found some differences between deep and moderate neuromuscular blocking. So till now, there is no clear evidence that there is a link between pain and deep neuromuscular blocking. Now I think we have a clear question to our second, clear answer to our second question, which is, does it worth to deep neuromuscular blocking? And the answer is yes, it worth, because it gives us better surgical conditions, means a faster surgery, means less complications, means less risk of injuries, which can be done by the surgeon during the surgery. So does it work? Yes, I believe, and according to guidelines, for getting a better visualization, yes, it works. Now let's go to the third question, which is, would you use neostigmine or Sugammadex for reversal of your agents? Please, who believes that Sugammadex, who prefers Sugammadex is better than neostigmine? Please raise your hand.
Sure, no, that's
It's up to you, because I see here about 50 or 60% from the audience, for the people who see us from the online broadcasting, who doesn't believe that in all cases we should give Sugammadex. And let's see by evidence, is it which is better, Neostigmine or Sugammadex as a reversal agent. The American Society of Anesthesiologists used 10 randomized controlled trials reported a lower incidence of residual neuromuscular blocking in patients antagonized by Sugammadex compared with Neostigmine. And time to 3/4 ratio greater than or equal 0.9, which is the point of extubation, were shorter in patients antagonized with Sugammadex compared with Neostigmine, and from deep to moderate depth of blockage and from shallow to minimal depth of blockage. This comes in the guidelines of the American Society of Anesthesiologists. And also, the risk of anaphylaxis. Risk of anaphylaxis was reported in Neostigmine in only one study. And the risk of anaphylaxis in Sugammadex, according to the records which is mentioned in the American Society, is 1.6 per 10,000 when you use when you use Sugammadex. While the risk of bradycardia or tachycardia or arrhythmia, there were no apparent among the patients who received Sugammadex compared to Neostigmine, and the risk of tachycardia here with Neostigmine because of the glycoviolet when it's given with Neostigmine. We can see here this table of evidence, which is comparing Sugammadex with Neostigmine for incidence of residual neuromuscular blocking and time to recovery. And this table of evidence used here you can see 8 trials, and there was patients about 1,451 patients, and you see here the ratio is 0.07 to 0.42 between Sugammadex and Neostigmine, and 33.8 to 9.4 between Sugammadex and Neostigmine. Also, regarding the shortened time to 3/4 till you reach the point of extubation, which is more than 0.9 in the deep neuromuscular blocking, it was 59.3 versus 7.9 Sugammadex to Neostigmine, and in moderate block it was 12.7 versus 7.2, and in shallow block it was 0.6, 1.6, and in minimal block it's 2 versus 0.8. So it's clear now that when you are caring that your patient have a better time from, or shorter time from 3/4 from the depth of neuromuscular blocking to reach the point of extubation, it's proven that Sugammadex can shorten this time and you can have a faster extubation when you use Sugammadex. And also the risk of neuromuscular blocking residuals when you are using Sugammadex is much less when you are using versus when you are using Neostigmine. This is another table of evidence, but used by the European Society of Anesthesiology, and is comparing Sugammadex with Neostigmine for incidence of residual neuromuscular blocking. And you can see here in the first trial, they used Sugammadex versus Neostigmine, and here the results come in Neostigmine 3 versus 0, and in the second trial, also trial, they are comparing Neostigmine to Sugammadex, and we here can see the risk of residual neuromuscular blocking in Sugammadex group is better than the group of used Neostigmine. So the risk is less when you are using Sugammadex. So we come to the guideline. We have a clear guideline that comes from the European Society of Anesthesia and the American Society of Anesthesia. In the European Society of Anesthesia, they recommend using Sugammadex to antagonize. I don't think they have bias, okay? the European Society. But they recommend using Sugammadex to antagonize deep or moderate and shallow neuromuscular blocking induced by aminosteroidal agents like procuronium or procuronium, deep postoperative count more than 1, and TOF count 0, moderate. They are defining now the deep or moderate or shallow neuromuscular blocking. And so, and for the American Society, they recommend the Sugammadex over Neostigmine at deep, moderate, and shallow depths of neuromuscular blocking induced by procuronium or procuronium to avoid residual of neuromuscular blockage. So we suggest neostigmine as a reasonable alternative to Sodium at minimal depth only of neuromuscular blockage. So it comes here is the guideline of the American Society that in the minimal depth of anesthesia, that time you can give a neostigmine. But in other levels or other depths of anesthesia, of neuromuscular blocking, it's recommended here by the two societies to use Sodium as a reversal agent when you are using Procuronium or Procuronium as an induction agent. Let's keep it to the end. I think now we completed 3 questions from the 4 questions, and let's go to the next questions. Do we need to monitor muscle relaxants? Can you please tell me, do we need for all patients using neuromuscular blocking? Okay, for the 3, I see here 3 of our audience said that we need to monitor neuromuscular blocking. From you 3, who is really using neuromuscular monitor for all his patients? I cannot see anyone of the 3 raise their hands. Okay, let's go to the next slide here. The American Society of Anesthesia, they put standards for basic anesthetic monitoring. You know, standard 1 is the anesthesiologist himself, and standard 2 is monitoring of oxygenation, ventilation, circulation, and temperature. But there is another monitor which is the American Society is missing here, which is the neuromuscular monitoring. Here we see these recommendations comes from the Association of Anesthetists of Great Britain and Ireland. They recommend in 2021 that quantitative neuromuscular monitoring should be used whenever a neuromuscular blocking drugs are administered throughout all phases of anesthesia, from before initiation of neuromuscular blocking until recovery of KRNO4 more than 0.9 has been confirmed, and this comes in the recommendations of Association of Anesthetists of Great Britain and Ireland. Also, we can see another recommendations and another guidelines from the Canadian Society. There is a recommendation for the use of neuromuscular monitoring when neuromuscular blocking agents are administered has been strengthened from should to must be utilized, and neuromuscular blocking monitors are now considered required equipment when previous were only exclusively available when neuromuscular blocking agents are used. So using a neuromuscular monitor is must when you are giving your patient a neuromuscular blocking agent. Comes here also another guideline comes from the French Society, which recommends an intraoperative monitoring of neuromuscular agents throughout all phases of anesthesia in both operating theater and also in post-operative post-anesthesia embryonic. And the point of 0.9 TOF is the point they recommend for extubation. What is the objective of neuromuscular monitoring? The objective is to detect the onset of neuromuscular blocking and to determine the level of muscle relaxation during surgery and to assess patient recovery from neuromuscular blocking. Let's see what's the methods of neuromuscular monitoring which you know. First is the clinical test and qualitative evaluation and quantitative monitoring. Which methods of neuromuscular monitoring usually is used here? Most of us are using only clinical tests. Open your tongue, open your mouth, tongue out, raise your head. Is this methods of detecting is your patient reversible, not reversible enough or no? You will see now. Clinical tests we see in this trial, they detected the sensitivity and specificity when you are using the clinical test. We see here the sensitivity and specificity when you are using clinical tests are very low. The sensitivity is only 0.2, 0.2, 0.3. The most higher sensitivity here is the general weakness 0.35. So we have a low sensitivity and low specificity when you are using a clinical test only for detecting if your patient is reversible or not reversible from the neuromuscular blocking. Here's Professor Churchill-Davidson. Professor Churchill-Davidson on 1938, he was the first one who described that the nerve stimulator can be used for detection of the depth of neuromuscular agents. That was in 1958. And here comes a great professor, the Egyptian professor, Professor Hassan Ali. He's the one in Harvard. He's the one who, the first one who described the. He was the first one who described the trinophore, which we are using until now in operative theaters, which was, I think, in 1967 in Harvard University. Now, let's compare the qualitative versus quantitative monitoring. Qualitative monitoring is the assessment of visually or tactily the response of simulated muscles, and it's more reliable than clinical test, but it doesn't eliminate the risk of post-operative residual polarization, and the clinicians usually overestimate, especially at moderate level of loss. In the quantitative monitoring, it uses neuromuscular monitor device to stimulate and peripheral nerve while also recording, quantifying, and displaying numerical the evoked responses. And there's different techniques which you use quantitative monitoring. So quantitative monitoring is more specific, which is protecting our patients from residual neuromuscular block. With Socomedex, we agree now, according to guidelines, we have to give Socomedex to our patients, except if the patient is shallow sometime, you can give neosteroid. Now I'm giving my patient Socomedex. Do we still need neuromuscular monitoring? Can you raise your hand, please, if you... Okay, I see only two who raised their hands. And they said, yes, I give Socomedex to my patients. Now I'm giving, say, a deep neuromuscular blocking, and I'm giving Socomedex 4 milligram per kg. I give my patient it's my Socomedex, open your eyes, open your mouth. Okay, I will extubate now. Is it safe? Let's see this study, which says that reversal of Socomedex in absence of monitors didn't preclude residual of neuromuscular block. You can see here that 9.4 of patients who had Socomedex but not monitored, when they checked them in the recovery areas, they found their patients still colorized. So monitoring is a must in your patient, even if the patient received Socomedex. So please, I expect that we change our practice. I expect that all our patients should be monitored whenever you are going to give a neuromuscular blocking agents. They should be monitored to because when your patient reach the point of extubation, according to the monitor, which is QF more than 0.9 or 90%, that time you will extubate your patient and you are not fearing about a residual polarization, which is known complication, respiratory complications, whatever complications in the recovery and post-operative complications. And you are protecting actually your patient. Here is a table of evidence that shows that the quantitative neuromuscular monitor versus qualitative neuromuscular monitor, and you see here, according to this, I can see 6 studies, which is used by the European Society to put the guidelines, the superiority of the quantitative neuromuscular blocking versus clinical criteria or versus only qualitative neuromuscular blocking. See the numbers here. It all says that it's more superior. And here also there's a table of evidence which has studies used by the American Society in comparing quantitative versus qualitative versus clinical science, and all the studies they used, it shows that quantitative means that the machines we are using in our ORs, which are showing the TUF, this is the quantitative, okay, which is more superior to the qualitative methods, or qualitative means to attach it, to attach your neuromuscular monitor, but you are only watching the switches and you are evaluating the switches with your eyes. You are not using a machine which gives you numbers. This is the qualitative. Okay? Or the clinical science, which is open your mouth, raise your head, or raise your hand, which is clinical test suite. So all the studies say that the quantitative is superior to qualitative. Now we go to the guidelines. The guidelines in the American Society of Anesthesiologists said that we recommend quantitative monitoring over qualitative, assessment to avoid residuals of neuromuscular blockage. And also it recommends using adductor process muscles for the neuromuscular monitoring. And the European Society says that they recommend the use of ulnar nerve stimulation and quantitative neuromuscular monitor at the adductor process muscle to exclude residual paralysis. So both of guidelines, they agree that quantitative neuromuscular monitor is essential and to use adductor brushes for monitoring of your neuromuscular monitors. And also there's another addition from the American Society. They say that when neuromuscular blocking drugs are administered, we recommend against clinical assessment alone. Okay? And to avoid residuals of neuromuscular blocking, and they recommend against using eye muscles, which is one of the clinical tests for neuromuscular monitoring. This is not a method, even opening eyes is not a method to evaluate, it's not one of the clinical tests which is approved that they recommend using this clinical test as a measure to know if your patient reversed or not. Another two recommendations comes from the American Society of European Society. The American Society says that we are confirming that the train of 4 greater than or equal than 0.9 before extubation, and the European Society said that before starting neonatal beam based on reversal and continue quantitative monitoring, blockade until TOF ratio is more than 0.9. The American Society of Anesthesiologists has some addition regarding using atracurium or cis-atracurium. And they said that to avoid residual blockade when using atracurium or cis-atracurium, the qualitative assessment is used. We suggest antagonists with neostigmine at minimal neuromuscular blockade depth. In absence of quantitative monitoring, at least 10 minutes should be elapsed from antagonist to extubation. Okay? And the second recommendation is that when quantitative monitoring is utilized, extubation can be done as soon as strain of 4 is greater than 0.9. I think now we answered all of the 4 questions we came today to answer according to the recent guidelines. And let's review this in fast. Muscle relaxants facilitate intubation and reduce airway injury. And rocuronium can be used for rapid sequence induction with presence of pseudomodex inside the operating room. Also, deep neuromuscular block is recommended to improve the surgical field in laparoscopic surgeries. And reversal with pseudomodex is recommended to reduce the risk of neuromuscular blocking residuals. And lastly, the quantitative neuromuscular monitoring and extubation with TOF more than 0.9 is recommended. Thank you very much for your listening.
Thank you very much, Dr. Ibrahim, for your rich and informative lecture. I'd like to invite our second speaker,